Hi there, I'm the neuromuscular mechanic, and today we're going to talk about ultrasound guided piriformis injections. So, what may these be used for? As the name suggests, piriformis, we're using it for piriformis syndrome. So, individuals who may complain of buttock pain that may radiate down the posterior thigh, that can be worse with passive stretch of the muscle, such as internal rotation, or activation of the muscle, such as resisted hip abduction. And so when I do injections, I go through a checklist. So similar to my other videos, we're going to review what the ideal patient position is, what transducer you should consider, where you can put your transducer to start based on surface localization, structures to identify on the pre-scan, and how to get to the piriformis. So if we start with the patient position, I will have patients on their stomach in the prone position. Now with the next part, what transducer do I use? Because it's a deeper structure, I'm going to need to use a curvy linear low frequency ultrasound probe to get that penetration to deeper structures. Very difficult to use a linear probe. And then with the surface localization, if you keep in mind your anatomy, so the piriformis, if you recall, runs from the anterior sacrum to the greater trochanter. And so what you can do is you can start your probe at the posterior superior iliac spine. That's often very easy to appreciate. You start in short axis, and then you would move the probe laterally to appreciate the ilium. And then from there, you can move the probe distally in short axis until the medial aspect of the ilium disappears, and you're left with that sort of greater sciatic foramen. And that's the area where we're going to see the piriformis that's underlying the gluteus maximus. And we'll review this. So with the pre-scan, structures to help identify, as I sort of alluded to, would be the PSIS, or the posterior superior iliac spine, the ischium, the greater sciatic foramen, the gluteus maximus, which will be overlying the piriformis, and then most importantly, the sciatic nerve. We do not want to inject in or around the sciatic nerve. There's variable anatomy, anatomical variation, but most often the sciatic nerve is going to lie deep to the piriformis. And we'll take a look at that in the upcoming videos. And then with the target, when I do the injection, I want to do it in plane, often using a spinal needle. You can go from lateral to medial or medial to lateral, and you're injecting into the piriformis muscle, not to the sciatic nerve. Now, to bring out that muscle, you might have your assistant rotate the hip with the knee flexed, and you can see movement of that muscle relative to the overlying gluteus maximus. And because we do not want to inject in or around the sciatic nerve, you can use an EMG needle that has a stimulator to ensure when you're confident of your placement, if you do stimulation, you shouldn't get activation of the sciatic nerve. So we're going to start here with the video. So I've got it in transverse plane, and now I'm over the PSIS. And so you see that posterior acoustic shadowing. So that's our surface landmark. And then what I'm going to do is I'm then going to translate this probe slightly more laterally to appreciate the ilium. So we're going to do this here shortly. So we'll just sort of wait here a second. And here we go. So I'm moving it laterally. There's my ilium. So you can see that border of the ilium and overlying it the muscle. What I'm then going to do next is then I'm going to move a little bit distally down the buttocks until I appreciate that medial border of the ilium disappearing. So I'm going right there, and there it disappears. So you can see that medial border of the ilium disappears, and I'm left with, as you can see here, just that part of the ilium. There's a space medial to it where our sort of greater sciatic foramen is. And then we see in that space the piriformis. And the piriformis, as we can recall with our anatomy, is coming off the anterior sacrum. That's where it's originating. And so the bony structure sort of in the left of the screen is the sacrum. And the reason why we like to start at the PSIS and then move distally is that of the small sort of rotator muscles in the hip, the piriformis will be the most cephalad, or closer to the head, compared to, say, the gemelli or the obturator muscles. And so this is why this approach works. And it also allows you to not mistake other muscles around this area, again, like the gemelli, the quadratus femoris for the piriformis. And so this is just another video, same thing, but what I've done is I've changed the settings around, and now I've brought out the sciatic nerve. And so you can see this very hyperechoic structure of the sciatic nerve closely sort of near the ilium there. And we do not want to inject around it. And so it's very important to identify it or to use that EMG needle with stimulation before you inject. And then what I'm going to do is I'm going to move things a little bit here. And if we just pause, with the red, the top red line and the bottom red line, that sort of makes up the outline of the piriformis. Again, tracking from the anterior sacrum and then sort of across. And then overlying it is the gluteus maximus. So if we're doing this injection, we're bringing the needle in plane through the gluteus maximus to the piriformis, injecting in the muscle, avoiding the sciatic nerve, and ideally using stimulation before we inject to ensure we don't get activation of the sciatic nerve, which would tell us we're in the wrong place. And again, here I'm doing some internal-external rotation. You can sort of see the contours better of the piriformis when I do that. So that's another technique. So I'm the neuromuscular mechanic. That concludes our video, and I hope you found it handy. Take care.